Thank you all of you for your attendance today. And Ruth is going to introduce the speaker today. Ruth, go ahead.
All right, thank you. Thank you. So again, I'd like to welcome back Dr. Judson Garrett that works with us extensively and works with the Kentucky Department for Public Health and the CDC as part of the Kentucky Infection Prevention Training Center. He is well known in the infection prevention and control community, as well as quality and patient safety. And I'm very appreciative of your time today, Dr. Garrett. And you'll be talking to us, giving us some updates about the risk assessment 2.0. What is it? How do we use it? And how can it save lives? So Dr. Garrett, let me turn it over to you. Thank you.
Awesome. Thanks very much. And thanks for the invitation, Dr. Ramirez, to be here today. As Ruth mentioned, I really wanted to talk specifically about this ICRA 2.0 and really what's changed. What does it mean for us and how can we utilize this? At the end of the presentation, I also want to give you some useful tools and websites that will allow you to make sure that your contractors that come in your building are up to speed and up to snuff as it relates to this important topic. I'm going to also provide an ebook at the end of today that they'll post along with the recording that will give you all the different resources, including both the ICRA checklist as well as the slides, in addition to the ICRA permit that you can use. And those are all available freely from ASHI as well. I've included the website for that. They do have a members only webinar that is available to you. So if you are so inclined, you could join the organization and then you can listen to that recording. What I've tried to do is take the real highlights of that, since most of us are not members of that organization, so that you've got that. And so we'll start off with what is an ICRA in general and talk about it in the context of reducing risk, right? We know that everything that we do in infection control is all about mitigation of risk. The second area that we'll do is talk about how to sort of associate that with different levels of risk. So the great thing about the ICRA tool is that it gives us a breakdown by types of procedural areas, the types of patients, the duration of the activity as an example, and how we want to rate that. And we're going to go through an exercise together. And so what I'm going to do for the exercise is use Ruth sort of as the hospital, and then we'll walk through an example of a construction project and how we can use this tool to our advantage. And then lastly, and probably most importantly, is people come in our buildings all the time, right? And we have very limited control, or so we think, over these individuals coming in and out. In reality, in our contracts with these workers, we should ensure that there are standards built in that say specifically they must follow all of our infection prevention and control recommendations, and an ICRA process must take place, as well as their personnel should be properly trained. So let's start off with a basic definition of what an ICRA even is. It's an infection control risk assessment, right? And primarily this is used in hospitals, but I've already seen some questions come in about, can this be used in other healthcare environments? And the answer is absolutely yes. Now, keep in mind that the majority of the definition work and sort of the examples are going to be more acute care focused, but there is a lot of utility that can be sort of pulled from this for any environment. And specifically places like skilled nursing, where we know that we have very vulnerable populations of patients and residents, we certainly can pull from that for sure. The actual sort of algorithm that's used was developed by many different organizations, but primarily through a group of infection preventionists, the American Society for Healthcare Engineering, which we call ASHI, as well as our colleagues down at the CDC. For those of you that are not muted, if you don't mind just muting your phone line for us, we would greatly appreciate it. Otherwise, we'll have to mute all the lines manually. So the ICRA process is not new, right? It's actually been out there for a long period of time, right? Back from the 1996. And really it was broken down by different elements of functions. And so infection prevention and control, industrial hygiene, construction, as well as our facilities personnel. Now, all of these people together really brought together sort of a better algorithm that was more comprehensive with clear definitions. For those of you that are working with things like the NHSN definitions, we know sometimes there can be a little bit of ambiguity, right? It's a little bit vague. And so you'll find that some of the big changes between ICRA 1.0 and ICRA 2.0 are to sort of alleviate some of those areas that were a little bit gray and make them a little bit more black and white for us. So this process started, no surprise, during the pandemic, right? And so it's been almost a 2-year process that ASHE has worked through, and we're very thankful for them taking on this work to bring these guidelines to bear so that we could have something that was a little bit more formidable, but also use it as an accountability tool for everything that we do in healthcare as it relates to construction. So there are different types of construction activities, and we're going to go through the 4 main types here. Type A is going to be your expanded construction activities. And so what we found here was that the change was they broadened that sort of building system maintenance. So they include things like our tube systems or HVAC, our fire suppression, any electrical or carpentry work, as well as painting. And so this was an expanded definition from ICRA 1.0. And we'll actually go through this in the tool here at the end of the program. One of the other things that they looked at specifically was sort of changes to patient risk groups, right? And so what they were looking at here was, are all patients really the same? And of course they're not. And what they found here is that they looked at like patient care support areas that were not part of initially the risk areas. And so they've now placed them into medium risk areas. Your ICU units, for example, have gone up a notch, and we'll go through what those look like here in just a moment. But again, our goal is to look at the risk of the activity, the duration of the activity, as well as what mitigation steps would need to take place. And we'll talk about what those are here in just a second. So what about high-risk categories, right? So this was a really sort of hodgepodge in the original document, and that, let's just say that more like med-surg activities were classified as lower risk, and of course our intensive care procedural areas were always classified as higher risk. And what you find here is that all of the patient care areas have actually been moved to the high-risk category, and then anything that's considered invasive, more of those procedural areas like our IR labs and ORs and places like that have moved over to the highest risk category. So again, it gives a little bit more clarity as to that all patient care, with the exception of our high risk invasive areas, are going to be in that high risk category, whereas our invasive areas have now moved to the highest risk category, if you will. Type C is really going to look more at large scale and longer duration activities, right? So this is going to be something that's not going to be a small project, but it's not a massive project. It's definitely going to create some atmospheric waste, if you will, from a dust perspective. You're going to have all of that type of stuff. Maybe you're removing drywall, or some examples here, dry sanding. All of that's going to be considered here. Now, once we get into sort of type C, one of the other added elements is looking at the surrounding area. How do we make sure, for example, that the patient still has a decent experience from a sound perspective, right? All of this type of construction creates noise, and we know that noise is extremely disruptive to patient care areas. It certainly can also be disruptive to sleep and some of the other things that we want to make sure our patients are getting. And so that's going to be an added thing that is not only on the permit, but also in the checklist itself. And then type D has expanded to include removal or replacement of building system components. So really we're thinking about that large, more sort of new building construction, or if we're going to renovate 2 or more rooms. So again, we'll go through some examples of this here in a second. And then from this, we're going to then look at the type of activity that's being done, again, that duration, and the patient care environment to determine what's our overall risk category. That risk category now in ICRA 2.0 is going to trigger what we call minimum infection control recommendations and mitigations. That's a way that we can then say, based on this risk, here's what we're going to do in order to try to stop that risk from ever reaching the patient in the forefront. So just a couple of side-by-side examples so that you can get some good visual representation here. On the left, anywhere it says ICRA 1.0 is our previous document that we're using. On the right of these tables, you'll see this is now the ICRA 2.0. And so this just gives you an idea of how much was actually expanded here. So if you look on the right, for example, you'll see now fan shut down, and startup is added. Controlled sanding activities, whether wet or dry. That's all been added here for type B. If we look at the high risk areas, again, on the left was our 1.0 recommendations. And so, that was primarily going to take care of our higher risk areas that had a different acuity, different types of risk, more immunocompromised patients. But on the right, you'll see that all of our patient care areas, with the exceptions again of our invasive areas, have moved into that high risk category. So what about medium risk? This has sort of changed a little bit because, again, on the left, we had specific sort of diagnostic and therapeutic services like cardiology and endoscopy that were listed as medium risk. Those have now changed, right? And so our medium risk areas are now going to be things like waiting rooms, your clinical engineering, your non-clinical departments, with the exception you'll see of sterile processing. So the dirty side of sterile processing is still considered medium risk. And then keep in mind your other public areas like your kitchen, your cafeterias, gift shops, places like that where visitors might be involved are going to be in that medium risk category. And then lastly is your low risk areas. Really on the left, you saw that in 1.0, it was all office areas. And now in the 2.0, it's really your non-patient care areas. So offices, break rooms, mechanical rooms, closets, that type of stuff, pretty straightforward, will be classified in the low risk category. So what about your type B? Actually, we just went through that. So let's go to this. This is your actual permit. And we're going to pull this up in a PDF here in just a moment that we'll be able to use. The other thing is I'll provide you the full PDF for both the permit process as well as the checklist in addition to the slides. I'll also send you a link to a great article that sort of summarizes the differences that was published by ASHI. But at the very top of your assessment and permit, you're going to start with that project name. What's the number for the ICRA that you're doing, sort of the start and end date, all of the basic stuff. Your foreman and supervisor, right, is important because that should be somebody with a higher level of infection control knowledge. And many of you may not be aware, there's actually a new certification for this process that construction and other industry personnel can go through to bring their level of knowledge base up significantly so that you can have more confidence in this. Then you're going to look down at that type of activity. Is it going to be type A, non-invasive, type D, the small scale, short duration, type C? Now we're jumping up to that large scale or longer duration. And then type D is always going to be considered sort of that major demolition or construction. You want to put your rationale. That is important. And I would encourage you to have somebody else double check this, right? Don't do this in a vacuum. Do it with, multiple different parties so that you're coming together as a team and you're looking at this from all different lenses to ensure that you're addressing any potential patient safety risk that might cause harm. Step 2 is going to be looking at the patient risk area, as we just identified. So let's say, for example, that we're going to go in and we're going to knock down the wall between OR1 and OR2. Well, we know that that's going to be type D. So we're doing some type of major demolition. We're going to completely renovate both of those suites. So we're looking at multiple areas. And we also know that based on the patient risk area, that's going to be the highest classification because it's an invasive, sterile, compromised area. And so that's going to be our recommendation for that. Once we determine that, we're going to go down and say, okay, we're looking at type D, and we're really looking at that highest risk, which is going to put us in V. And that's going to help us dictate what type of infection control recommendations and mitigation should actually be triggered. And I'll show you an example of that here in just a moment. The other piece that I mentioned earlier in the program was about this concept of the surrounding area. Right? We're really trying to make sure that not only do we not harm a patient from a physical standpoint with an infection control risk that's preventable, but we also want to make sure we're putting in place good logical controls to prevent the patient from having a bad experience, from seeing dust, making sure that ventilation is still adequate, and really that noise is also going to be well controlled. Nobody wants to have construction in the hospital at 3:00 in the morning, regardless of where it is, because as we all know, it can echo throughout the facility. And so this will, again, allow us to think about what mitigations do we need to take, and then who do I need to get involved? For example, let's say that I'm going to interrupt electricity. Well, I know I need building engineering. I need facilities. I might need an electrician, right? Or if it's mechanical, I might need to get engineering up there, up front. Maybe I need an outside vendor like my HVAC system company. And so this will give us a better idea as we permit about how to plan accordingly. So before I go through a couple examples, I wanted to just quickly sort of recap on, again, the benefit, right? We first want to make sure we're moving to this new tool because from an industry standpoint, this is the new standard. So ICRA 1.0 is essentially gone, and we're going to use ICRA 2.0 as that primary risk reduction tool and for purposes of permitting new construction activities. We also want to make sure that contractors are properly trained. right? And again, this should be specific verbiage that's in all of your contracts with any person or entity coming into your building. It can be something as simple as must follow all infection control recommendations, policies, and procedures, and any directions from the infection prevention department. The other piece I would encourage you to do is take it a step further. Require at least the supervisors of those teams to be certified in ICRA. And I'll show you a resource to be able to do that, that you can make them go do that on their own, but produce that documentation to you. I will tell you, as somebody who's taken the classes with that organization, they do a very nice job. It is extremely tedious and thorough. And so it definitely gives everyone that's involved a different appreciation of how construction and all of the building services can work collaboratively with infection prevention. And we know that the environment is changing every single day, right? And so the more that we can get ahead of this and do risk mitigation, the better off we will be. So these are the certifications that I had referenced earlier in the program that I wanted to make you aware of. I've also included the website on the next slide so that you can click that, and it's a live link. It'll take you directly to that. For purposes of infection prevention, you would want to make sure that the bare minimum for people in your building would be the certified healthcare worker, right? That is a 3 to 4 hour program that is very, very frontline focused. There's no extraneous information. There's no, fluff in it, if you will. It is really geared towards that frontline worker of what their responsibility is, and recognizing core risk and then notifying a supervisor is really the core essence of that. You can also see that there's a certified healthcare manager. That would be what you would want to have somebody that is your foreman or your supervisor on site complete that program. That program is a 16-hour program, 2-day program. They also have the facilities technician, which is really great for your specialty contractors like HVAC, people that might come in and service the water, folks that work on that type of stuff. And again, that is an 8 to 10 hour program. And then lastly is the healthcare remediator. This is excellent for infection preventionists to take as well, because it talks about the different levels of remediation that could take place in a building. And primarily that's going to focus on risks like molds and fungal organisms. So it's a very, very helpful program to take. All of these, they do deliver virtually as well as in person. And like I said, I've included the web link here so that you've got that. It's the first web link there. The second one that's listed there is the ASHI web link. And this, again, will have your direct link to the tools, which I'll provide you as a PDF so that you've got that. So with that, I'm going to stop real quick and switch the screen and bring up the PDF so that we can sort of walk through an activity. And Ruth has graciously agreed to be our guinea pig here. So let me just pull that up really quick here. So Ruth, I know that you're doing a construction project at your facility. Can you tell us a little bit about where it's going to be done?
Yeah, so the construction is going to occur in the mother-baby area.
Okay.
So we're going to be trying to make it more accessible and look nicer for our families. So they want to come to our facilities to deliver their babies. So a lot of facelift work will be going on.
Okay, so let's just walk through this for a second as if we didn't know what category we were going to be in. So I know you've identified that this is a fairly high risk area. This is our mother baby. Is this also a location, Ruth, where there'll be a NICU?
Well, it's very close. It's very close to both the newborn nursery and the neonatal ICU. Now, I don't know about the ventilation, what type of ventilation is shared, but I do know that it's close in proximity.
Okay, so if we look at the definition for type A, based on what you're telling us, that this is going to be a fairly moderate facelift, right, to give the unit a new look and feel, it would probably be reasonable to exclude type A, right? We're not doing any type of just basic ceiling removal. We're not doing any clean plumbing, right? So we'd really be looking at type B and type C as an initial starting point. So how long do you think that this project's going to take?
I think it's slated for about 6 months.
Okay, so if we know that it's not going to be short duration, right, and it's going to go into that more aggressive construction project, we can now rule out type B. So let's drop down to type C and type D. So based on what the construction, plans are we looking at renovation of like a single room? Are we looking at, just some basic drywall? Are we looking at major demolition?
Well, the desire is to make all of the rooms larger so they can serve as, a complete suite. So when mom comes to the hospital, she'll labor in that room, deliver in that room. The baby then can room in that room. So it will be a fairly large. It's not a lot of rooms. It's only maybe 15 rooms.
Okay.
But there's going to be some significant facelift work in there. But it sounds like it's probably more involved than we thought initially. And that if we're doing facelift work, then we may be involved in some of the ventilation, and certainly we may have to move some plumbing. So I think there's going to be some additional background questions that I'm going to need to ask so I can be clear in terms of the amount of work.
Perfect. So based on what you're describing, I think we would both agree that we've now ventured into type D, right? So we're looking at that more invasive renovation work, 2 or more rooms. So you're talking about 15 total rooms. There's probably going to have to be, HVAC system, ducts and stuff move, that type of stuff. And we're certainly going to have to deal with drywall. So we can identify that we're dealing with a type D situation here. Now let's go down and look at based on what you said. So you said this was going to be a mother-baby unit directly adjacent to our NICU. So would this be a low risk, a medium risk, a high risk, or a highest risk based on the ICRA 2.0, based on what your interpretation is?
So my interpretation is it's going to be high risk or highest risk, because we tend to consider the babies as particularly at risk. And we know, just a pregnant woman, being pregnant is an alteration of the normal immune system and immune response. So we're going to have the little ones and the moms. So I'm going to be inclined to be leaning toward the highest risk.
I would agree. And I think back to your point too, understanding from a systems engineering standpoint, where is everything connected? Right. So if that's the same system, for example, that mother baby's on, but it's also connected to the NICU, and we may have, drawback into the system that way, I would agree with you that highest risk, you're never going to be faulted for going for a higher risk. You certainly could be faulted for going to it for too low of a risk. So if we're looking at a type D and the highest risk, right now we're getting into this environment where we're going to look at this here and we're going to go down and say, okay, we're in the highest risk, which is going to trigger category V. Right? This category V is so helpful because it allows us to determine the types of mitigation steps that we're going to put into place. So if we keep going down through this document, now we're going to look at that surrounding area assessment. So as Ruth just mentioned, we're not just working on the mother-baby unit, but we also directly adjacent have a NICU. And so we know that noise sensitivity, especially in that environment, is of huge concern. And so we may need to look at doing some soundproofing, certainly deal with dust control, make sure that especially as staff go back and forth, because they likely do. Maybe there's a joint supply closet or something like that, or supply area that's a core. We have to address all of that. When you look at your systems impacted, this is going to tell us who else needs to be involved, right? What can we do to sort of mitigate that risk? And if from a noise and vibration standpoint, you'll see that they have multiple, over 10 different mitigation strategies that are now directly listed here. What I love about this is that you don't have to remember them. They're already there on the form. And so you can sit down with the contractor and say, which of these is going to be the most effective? What can we deploy? How many of these can we deploy? That will allow us an opportunity to try to cut down on any of that impact. The same is going to be true for the other areas like ventilation and pressurization. Can we do some type of HEPA filtration to the outside as an example? Do we need to vacate the area totally? Is this an area that's safe for any types of patients? Let's just say hypothetically with Ruth's example that this was an uncontrollable situation where we're not able to bring in fresh air to the NICU while we're doing this mother-baby construction and that unit is closed. Well, that certainly would have negative impacts to our NICU environment. And so we may have to look at relocating those babies, or maybe we have to change our construction approach altogether, or create some other type of barrier. And then your systems mitigation is going to include things like, is IT going to go down? Are the computer systems going to go down? As much as we all hate electronic charting sometimes, we also definitely hate paper charting. And so if something's going to go down, that's going to prevent us from using our normal systems of operation. Or what if I can't get into my Pyxis machine because there's some type of internet connectivity issue? So from these, you're going to drop down and look at your risk mitigation categories. So you're going to see class 1, class 2, class 3. on the left. And we know that this is going to be a class 5 here. So we're going to drop down here and look at all of the different things that should be triggered by this risk classification. Again, this should be a checklist that we're all using jointly, not just infection prevention, not just building services, but also the contractor. And so as you do your permitting process, you do your rounding, as well as have maybe your weekly meetings with the contractors, you want to ensure that these things are always top of mind, right? Sort of your cheat sheet, if you will, to make sure that we're doing everything correctly. They also have incorporated the latest in air filtration standards here. So you'll see down towards 6, 7, 8, 9, 10, where they've included the HEPA filtration information so that you've got that, as well as some things that are not recommended, such as exhaust into shared or recirculating HVAC systems, right? So again, this is designed to say, based on my risk of the activity, the duration, the location, as well as the type of patient population served and the procedures performed, this is what's going to be triggered, right? And again, you can always go above and beyond, but you don't want to go below the minimum. If we get down here, you'll see some other risk mitigation things like for cleaning, as well as your HVAC systems. This is upon completion of the activity, right? So before we turn that area back over to the clinical team, we want to make dang sure that everything is as it should be, so that when that clinical care environment is reopened for patient care, that everything is exactly in the manner that we intend it to be. And we're going to mitigate those risks accordingly. And at the end here, you'll see some other recommendations for your negative air and your HVAC systems. So I want to switch gears for just 1 second as we finish up and show you the permit process. And this is even more simple, so that you've got that. This is only a 2-page document. And again, we looked at the first part of this here a minute ago. But as we get down into this classification, so we're going here, we're going to say we're going to do type D. Based on Ruth's assessment, we're going to go with highest. So we know that if it's type D and it's highest, that's going to classify us there. Let's say that we want to look at the NICU. We can type that in here. We know that the risk group is extremely high because this is your highest risk patients. And let's say that we're going to actually take upon all of these controls. And we know that we're going to need mechanical, our gas, hot water, and let's just say some other things. Then you can put in there your discoveries that you did upon your permitting and walk-around process so that you capture all of that, things that might be unique to your building and your patient environment that you may take care of, or your system as it's designed. And then lastly is your detailed work plan for the ICRA controls. And again, this will allow you to make sure that you can do this. You'll notice if you click this here, you can then select the classification from the dropdown. And that'll allow you to go down here and put your controls in. My recommendation would be to create one of these permitting tools for each of the 5 classes. Save that as a template so it's ready to go. And then that way you have something that's a homemade template that you can use for any permitting process, regardless of the classification of the project. So again, I know this is a ton of information. We wanted to make sure we brought this to you pretty quickly after it was released. It's only been out less than a month. And as I mentioned earlier, I'll make both of the checklists available, the permit as well as the general checklist. I'll send you a link to the ASHI webinar as well as the article as well. That'll all be in the ebook that'll be posted with today's recording. So with that, Ruth, I'll turn it back over to you to see if we've got any questions or any comments that you or Dr. Ramirez want to add.
I think this was a great overview, and I think that it's a reminder on why we have our construction plans and water management plans, and how all of those link together. I saw some questions in the chat about we tend to think that only hospitals have risks associated with construction, but we also have a lot of our IPs that are working in long-term care facilities. Can you just describe some of the considerations for the use of this type of tool in long-term care?
Certainly. So, I mean, there's no exclusion for using this in other healthcare environments. Long-term care, absolutely. Not only do we have high-risk, vulnerable resident populations, but certainly, as we all are aware, our long-term care facilities are not always in the best of repair. And so we've got some, environmental challenges there for sure. Another environment that I commonly see ICRA's used for is ambulatory surgery. When they're going in and doing renovations, especially as we add different service lines, maybe we're putting in, different therapies. You can see this especially in outpatient oncology areas. Dialysis would be another area of high risk, especially from a water contamination standpoint, as we're certainly aware. So it really is an agnostic tool that can be used in any healthcare setting. Again, some of the verbiage that you may see from ASHI is going to be a little bit more acute care centric. I also hear frequently a lot of confusion between the ICRA and the ICAR. So, people may get a little bit confused between those two things too. So just a little food for thought, but definitely has application to any healthcare setting.
So both of those tools, as you mentioned, are for a risk assessment.
Correct.
It's just determining what you are assessing, and this is for the construction or renovation or anything involved in changes in the healthcare environment. Now, we had a lot. Another question that I have. We had a lot of discussion about previously areas like waiting rooms and bronchoscopy suites were slated as negative pressure environments. And we know over time, as buildings change and waiting areas change, now that was kind of a movement away. But with COVID and with the involvement of ASHRAE, another organization, we talked about ASHI looking at primarily the healthcare environment. ASHRAE looks equally as importantly at the ventilation systems. What do you think? Do you have any thoughts about how COVID may have influenced or may continue to influence this risk assessment and with the input from these additional associations? Just maybe something that we need to put on our radar thinking about.
I mean, definitely there's going to be areas that are going to have a different level of risk. And I think bronchoscopy, as your example, is a perfect one. We know that from a provider standpoint that AGPs are going to be more common in that area than most likely other places in the facility. So that certainly could change. But again, the procedural area itself is pretty easy because that's always going to be that highest level risk. But to your point, yeah, and it's also a procedural invasive area. So by definition, it's always going to get into that final category of highest risk. But I think the waiting room, it's pretty clear in the new guidance that is not going to be classified as such, even if it's attached to that area. So if it's a non-clinical area, they've made that pretty crystal clear. And that, again, was a multidisciplinary committee that looked at this, that waiting rooms are not classified in that category anymore. So even if they're
even emergency department waiting rooms, where you may have triaged, if you're overfilled, then you may have patients waiting because there's no bed availability. So I just bring that up just to show everything isn't cut and dry, that the IP still needs to be involved in some of the discussion and really looking at how a particular area is being used and how does that impact risk.
Yeah, and you'll notice that the emergency department in the ICRA 2.0 is classified as high risk anyways. So I think it would be very safe to just go ahead and make the assumption, because I mean, to your point, the ED waiting room is not really a waiting room, right? It's more like a holding pen of very sick people that are at different stages, to your point, in triage. So, if everybody in the holding pen is sick, and they all are, right? Nobody's really coming to the ER because they're just excited to see us. I think it would make complete sense to go ahead and just classify that waiting area as more of a clinical area, because truly we are delivering some level of care through the triage process. And I think that would be a very reasonable interpretation of that. And I think that's great, because it is definitely something that we want to be aware of and think a little bit outside of the box. And that's where that critical thinking comes in. And again, my recommendation personally would be, if you're ever in doubt, go to the highest level, right? Go to the next level up, because you're never, ever going to be faulted from a legality standpoint in taking more risk mitigation steps than if you were to take too little, especially in the environment. So great question.
Right. Any questions from the audience? I think everybody is struggling with this and what to do with it, because this truly is a change that we are undergoing. We're increasingly more involved in figuring out how our engineering departments, our physical plant, environmental services are involved in doing a recap. So, with them about kind of, where are we now? with construction projects, whether it's in hospitals or the other settings that you mentioned. So if anyone has any comments about their recent experiences or anything they want to share, please unmute and share that.
Yeah, there's another question in the chat too, and it's where does the permit need to be posted? Does it need to be posted at the site of construction, or can you just put up a sign saying it's on file on the location? I would absolutely put the permit on site so that it is immediately available for inspection by any party. I think that's obviously a little bit different than what we do with like elevators, where a lot of times it'll say, elevator certificate on file in maintenance office or something like that. For purposes of this, because we're doing physical risk reduction and we're dealing with health and safety, it would certainly be a best practice to actually have that permit displayed at the site. And I would encourage you to also put in there the risk mitigation strategies that are being taken and sort of the cadence at which you're monitoring it, so that you can, anybody can walk by. Let's just say that Dr. Ramirez is an ID physician, walks by that site and was like, wait a minute, this looks weird. He can instantly look at the permit and know what steps are being taken and look at the site and say, wait, we're not in compliance here. We've got, gaping holes in the wall or whatever it may be, and that we can sort of address those as is. So I would put it at the site.
I don't see any additional questions, and we will do as we've done before. You are so gracious to pull together information and have it in an ebook. As we post the recording from today, we will also post that additional information, so it will be available for anyone that wants to go back and take a look at that and hopefully download it and use it within their own facilities. So I thank you very much for your presentation today. And Dr. Ramirez, can I turn this back over to you to close us out?
Yes, Hudson, again, very clear and very practical. I think it was very practical for all the infection preventions that were on the call. Excellent. Thank you very much. And again, thank you all of you for your attendance. As Ruth always mentioned, if any one of the attendants have any particular topic that you have in mind that would like any one of us, or we can, as always, we can invite experts from outside to review a particular topic that we try to maintain in the area of infection prevention, antimicrobial stewardship, hospital epidemiology, infectious disease. We have a big umbrella here in the institute. We'd love to hear from you. What is that you want for us to discuss in the ground rounds? Thank you for your attendance, and we'll see you this coming Wednesday.
Very good. Next Wednesday's topic is simulation in infection control.